Hello and good evening. My name is Jessica Harper, and I am a recent D&P graduate and health advisor to Senator Tom Cotton. Today, I would like to brief Senator Cotton and his stakeholders on a pertinent topic relevant to his upcoming election. Safe ratios save patients. Registered nurses are licensed by states and are educationally prepared and trained to care for patients. According to the ANA, nursing entails health promotion, protection, disease prevention, and patient and family-centered care. Many job descriptions for bedside nurses pull information from the ANA scope of practice in order to delineate expectations based on evidence-based standards. Bedside registered nurses are tasked to protect patients and promote their health according to the American Nurses Association. Part of this responsibility includes recognizing subtle but acute changes in patient status. While physicians spend valuable time at the bedside, evidence has shown that nurses spend nearly 20% more time at the bedside caring for patients and families, according to Butler et al. Safe RN to patient staffing ratios, while a current heated and divisive topic amongst employees and employers, is not a new and profound legislative debate. The discussion of safe RN to patient ratios began nearly 3 decades ago. 1999 was the year that California became the first state to lobby for and pass a bill that made staffing ratios a standard of practice. The California RN staffing ratio law was put into full effect in all acute care, psychiatric, and specialty hospitals in California by 2004. The Department of Health Services established unit-specific ratios based on expert testimony and public comment letters. This led to final ratios to be implemented in hospitals around the state, according to CASPRAC. Evidence from Aiken et al. 2010 revealed California's mandated RN to patient ratios are associated with lower mortality and increased nurse retention. Despite this evidence, only 2 states have RN to patient ratio standards, and nurses around the country are still defending their obligation to do no harm to patients. The cause for unsafe RN to patient ratios is multifactorial in nature. There are 2 lenses which we can best view this problem from, one being the bedside nurse and the other the hospital. Many RNs are leaving the bedside, and many are even leaving the profession as a whole. Has COVID-19 impacted these numbers? While possibly accelerating the issue, the nursing shortage is not a new problem. Delgado 2021 states that high RN turnover is a result of inappropriate staffing, dismal administrative support, and unsatisfactory, unhealthy workplace environments. The idea that inappropriate staffing causes nurses to flee from caring for patients at the bedside creates a circular problem, one that can only be fixed through safe ratio advocacy. Hospitals have traded their pride in being a haven for the ill and have instead become a business, amused only by pinching pennies. Hospitals and administrators have learned that nurses, while the backbone and heroes of the hospital, are dispensable, and working with fewer increases hospital profit, according to Tung 2019. One study conducted by Lassiter et al. 2021 indicated that each additional patient per nurse was associated with higher incidences of patient mortality, 30-day hospital readmission, and increased length of stay. Lassiter et al. Also estimated that over a 2-year study period, approximately 4,370 lives could have been spared and $720 million saved had staffing ratios been implemented in a New York hospital. McHugh et al. 2021 conducted a prospective panel study in Queensland, Australia. Findings concluded mortality in hospitals with RN to patient ratios was lower, readmissions were decreased, and there was decreased length of stay. This study demonstrates that better RN to patient ratios can result in both better patient outcomes and fewer costs. These policies are feasible financially and provide exemplary return on investment. It would serve you well to consult with bedside nurses at local hospitals in Arkansas, the mayor of Arkansas, upper management at local facilities, and constituents, including former patients. According to the ANA, there are currently only 8 states who have hospital-based committees. Arkansas should be added to the list if we aspire to create safe staffing laws. It would benefit your team to facilitate discussion regarding reasons hospitals are hemorrhaging nurses from the bedside. We need to discuss doing away with mandatory overtime and compensating bedside nurses appropriately. Additionally, with the help of the Arkansas Department of Health and hospital-based committees, there needs to be formal staffing plan created complete with RN to patient ratios based on department, severity of illness, and complexity of need. I urge you to consult with bedside nurses, local policymakers, and constituents to evaluate staffing ratios at local hospitals. Consult with the Arkansas Department of Health to establish patient-specific ratios. This was an integral part of California's process into transitioning to RN to patient ratios. This process should begin immediately. The end goal is to develop a bill regarding safe patient ratios. This would be greatly helped by contacting constituents and requesting public comment letters from local nurses and patients and lobbying for legislation that endorses the responsibility of the nurse and reinforces the importance of the patient life. This worked in California. I've drafted a rough timeline that meets well with re-election in 2 years, hopefully giving us time to see this plan come to fruition should it have enough support. Ideally, beginning in January of 2024, hospitals in Arkansas will begin to comply with the standards set forth by the ADH. By the year 2026, every hospital will comply with hopefully what will be the law. Massachusetts failed to implement strict RN to patient ratios in their ER, med-surg units, and mother-baby units in 2018, according to CACIC. They produced stricter ratios in California, though, and they saw little improvement after implementing ratios in their ICU, leading to this next proposal to fail. Yet, this could have been because they already had safe ratios, according to Samuel's 2018. Why is this important to Senator Cotton, you may ask? 55,009 nurses were licensed in the year 2020 alone by the Arkansas State Board of Nursing. While lobbying can present a financial cost, the potential savings, as mentioned earlier, provide proof that for many hospitals with unsafe staffing ratios, this could be a financial benefit. In August of 2021, UAMS, one of the largest hospitals in Arkansas, was on CNN claiming they had 230 RN positions open and they were offering $25,000 sign-on bonuses. Whether related to COVID or basic burnout, providing hospitals with regulations for safe staffing will prevent hospitals from having to offer outrageous sign-on bonuses and instead retain nurses and save money. Here you'll find my references, which may be beneficial as you debate over whether or not safe RN to patient ratios is important to you and your re-election. I do hope that you'll consider the evidence-based practice that you'll find in these slides, not only from the United States, but other countries as well.